Okay. So thank you so much, colleagues. I hope this will be our wonderful session and it will take us through the wonderful moments, and we will be able to learn from one another. So this is a session. I hope it will be brief. I will have some data challenges here. I'm connecting two gadgets. So the phone and the machine is consuming. But today we will be looking at a very short presentation. The most focus is on the case presentation by our student from Good Shepherd. I hope they've prepared enough to share the palliative care case, and then we will then summarize the case with the didactic presentation with focus on pain management for patients who are approaching death and dying. So it's more of a summary of most of the presentation we have. If you visit the YouTube channel, Mahlangu MNS, you will be able to access some of the videos on that didactic presentation. So without the waste of time that is already gone, may I request Mr. Elkele and the students to share your case? The right for you, Mr. Elkele, to share the slide is with you, so you can go ahead and present. I think another gadget is connected in the same room, so we need to shut the volume from one. You can go ahead.
Are you able to see, Tim?
Let me do this. Yes, we can see it, sir.
Okay. Thank you so much. We have Tanzile Mbuyisa here who will be sharing our case presentation, which is at Lubombo region. So I think she is ready now. Go ahead, please.
Good afternoon, everyone. My name is Tanzile Mbuyisa from Good Shepherd Catholic College of Health Sciences. Our case today is from the Lubombo region, like Mr. Lukele has said. We have a male patient at the age of 44 years old who is single. The main diagnosis was perianal cancer. The patient is on deteriorating phase, also an ECOG 4. The main problem of our patient was discrimination and stigmatization in the community concerning his condition. Also, he feels a burden. He also feels that he is a burden in the family, especially the siblings, since they cannot afford to buy him the colostomy bags. The chief complaint was he complained of anal pain and discomfort. Also complained of lower abdominal pain and dizziness sometimes. Pain assessment We have pain number one is the lower abdominal pain. Number two, the anal pain. The pain description of the lower abdomen. Our patient complained that the pain is burning, and it started 4 weeks. It lasted for 4 weeks. Yeah, severity was 5/10, which means it was moderate. Yes, it's moderate. Then inconsistent with the intermittent. Also the type of pain is incidental because, this is because when he tries to walk, then that triggers the pain. So also the impact of pain and functionality is moderate. Where for the management of pain, uses with opioids like tramadol and then the pain med on pain is partial. Then pain number two, which is the anal pain, describe it as aching. It's been for 2 months. Then pain severity is 6/10, which severe pain, which is also constant. Also a breakthrough. Yes, the impact of pain on functionality is severe. Also there to manage that pain uses opioids. Also the pain meds on pain is partial. The patient's vital signs were blood pressure was 120/74 millimeters of mercury, pulse 78 beats per minute, temperature 36.6 degrees Celsius, a respiration rate is 19 breaths per minute. Then move on to the distressing symptoms ranking. The patient raised no complaint of constipation, dyspnea. Then there was mild anxiety, moderate depression, mild fatigue, no nausea and vomiting. Mild cachexia, mild anorexia, mild stomia. Then we move on to the significant surgical history. Our patient was diagnosed with perianal cancer on the 12th of February 2024. He started chemotherapy on April 8, 2024, and he did 6 cycles. Then on the 4th of May 2025, he started radiation in South Africa and completed the therapy. Then past medication that was used by the patient. And the number one was tramadol, 50 milligrams, 3 times a day, and still ongoing. Number 2, paracetamol, 1 gram per rising need, also ongoing medication. Number 3, diclofenac, 50 milligrams, also per rising need, still ongoing medication. Number 4, bisacodyl, 5 milligram, Noctare, which means at night, so it's still ongoing. Then move on to social history and the patient's family history. Our patient was Our patient was unemployed. His mother is the one taking care of him, as well as the family members. He used to smoke as a lifestyle habit. He has a very weak support system since he was absent for many years. There are 4 family members living with him with 1 household. He has 1 child, and he is unable to support the child since he is not working. Neither the family is supporting him financially. The spiritual history. Our patient has a strong spiritual support from the church, since they have a social media platform where they share sermons and lessons. They also share prayer items, and support each other spiritually. Advanced care planning. The patient does not have advanced care planning in place since he stays at his parental home and has nothing to give to the beneficiaries. Better plan of care to improve quality of life of the client and family. Number 1 is to improve pain management. Number 2 is to sensitize awareness to family members about his skin condition and how to treat him the way he feels at home. Number 3 is to provide health education to the family members about caregiving and also end-of-life care. That's the end of our presentations.
Thank you.
Okay.
Thank you. Maybe I missed something. You said what is the stage of the condition?
Deteriorating phase, stage 4.
Stage 4. What is the functionality and the palliative care phase?
It's the deteriorating phase.
Okay. So in terms of functionality?
ECOG 4.
All right, thank you. Okay, thank you. I think most of us are able to pick some few points from the case. It looks like an interesting case to work on. There are nice things to pick, even though I couldn't pick everything. But from the data provided, I can say that this is a male patient, right? Diagnosed with the CA anal at advanced stage, stage 4. And now he is on the deteriorating phase. He has lost functionality, which is bedridden and inability to do work. And now he is mostly totally dependent on the families. So thus he was graded stage 4. Another things I've noted is that this patient has an experience of partial managed pain, and especially he is described to have most complaint of breakthrough pain, which present as incidental pain. And we have seen that, yeah, I think that's what we can see, and he is on tramadol. And I've noted also that this patient has lost family role, as in now he cannot provide to his sole child. That's what I've picked, but let me give the team the opportunity to comment on this case and add some facts on it, on how best this case can be managed and what can our students put in place before even they leave the practice. So this was a case by our Good Shepherd interns. So we can help them and the team manage this case. You can ask them the questions if there are things we feel we can't judge they are missing. So anyone who can add. So maybe I will just require maybe clarity on your plan when in terms of improving pain management. What will that entail in this scenario? Maybe if you can elaborate on that one. Maybe again on the rationale for the patient to be put on weak opioids and the frequency to be PRN. Maybe that can be my question on this case. That what will be the improvements actually be in terms of pain management, and then maybe the rationale for the patient to be put on PRN opioids.
Good afternoon, team. Because the interns were with me since we're at Lubombo region. So in terms of pain management, we felt like because since he is on the weak opioids, which is tramadol, and the pain there is not responding well to the tramadol that is being provided. So we were thinking of maybe liaising this matter to the physician. So maybe he can titrate, or maybe he can provide another opioid, which is a strong opioid, so to manage the pain, so that the patient cannot feel that breakthrough pain. Yeah, I think that's it from my side for now.
Thank you. Okay, thank you. Yeah, okay. I was also confirming because another issue maybe you may need to check, team, is the issue of the dose frequency. Uh, uh, I thought maybe to be a physiological issue, maybe in terms of lab results you have found there, which will inform you that the LFTs or the KFTs are not working well, which may force you to give PRN the tramadol. But I will suggest we give the opioids around the clock, and then we see from there if he is responding, because if it's PRN, the issue is the cultural religious interpretation of when am I feeling the pain, and then you'll find that the patient is already having higher pain. So, and then also I saw that the patient is experiencing what we call incidental. So if it's incidental, maybe my comment could be, we found the activities that normally result to the incidents that predispose the patient to the breakthrough pain. So then we can look how those exercises can be performed. Maybe we may find to give a pre dose before those activities so that the pain may not escalate. But then let's remove the PRN and give it around the dose. So tramadol can be given 8 hourly or 6 hourly, which would be 4 doses per day. And then you may start with the 50 milligram dose. And then if the patient is not responding well from there, and then with no history of seizures, especially, and then looking at the effects of cachexia, how far. But sometimes we may need to prioritize comfort over that one with close monitoring. So we may need to give then the maximum dose for a day, which will be the 400 in a day. So we give the 100 milligram 4 times a day. If he's still not doing well with that one, we will need really the stronger opioid. But if then the strong opioid is available in a local facility, we don't need to escalate the weak opioid. We better increase or give lower dose of the strong opioid and then withdraw the weak opioid, because the process, the pharmacokinetics of it takes a long way and the side effects are high, yet the effect it has on controlling the pain, it's lower. And you see that it has a ceiling, yet having the morphine will be so beneficial because it will help us titrate up and down easier while monitoring, especially at this stage of his life. That will be my observation, looking at that, even the opioids are not working well. So it's either he's not taking them well or the PRN prescription. So let's just put the 6 hourly and then see if he will respond very well. But if he's not, possibility might even miss the enzyme to transcribe this drug to morphine or opioid, to morphine actually. So we will need the stronger opioid. If then the supply chain doesn't have it, we may not wait for it to come. We may need to add the adjuvant, looking at how the pain behaves. Sometimes prioritizing taking the patient to sleep is better than letting the patient be awake and suffer, yet he's approaching his end at this point in time. So that would be my suggestion as far as the pain can be. That what I will see and then discuss with the families. Because if then you are going to add the adjuvants, you may need to educate them because they may think you have killed their loved ones if they see him sleeping and not waking up. So you may need to discuss with them on the issue of the doses we are going to give. But before maybe we add much, we may need to see how far we go with the tramadol. But it's not the best drug we have, but we know the context. Sometimes the location of our patient doesn't allow them to have access to morphine. We know that one. Especially now he's ECOG 4, you may find that even to access a prescription will be a difficult challenge because the physician will need to confirm. But we are hoping Hospice one day will be able to prescribe and dispense the strong opioids, especially for those who cannot. Like if you go to Matubeni, there are no clinics, there's no water there. And then another issue I've noted, the reason I was asking is the issue of the functionality stage of the patient. I'm not sure in terms of the caregiver, because I'm looking at the patient stage 4 now, which is total dependent on the family or the immediate caregivers for ADLs and IADLs. So I'm just concerned, I don't know if the team could share if there's anything done in as far as what's the plan concerning the caregiving burden. How far is the patient performing in terms of burnout? That's what I will say. And then I will also be concerned because also there's this loss. I don't know, maybe the team can comment about that one. And then another one, maybe to comment together, team. This is another Nompumelele saying that I think also there's a need to assess some other factors leading to the pain. It may not be necessarily be only the physical, maybe try to probe more and counsel according, since I saw the patient is feeling as a burden. So how is that one, team? Maybe commenting on both these two issues, acknowledging Ndobe Mpumelelo's comment that we may need to probe, go beyond the physical one, look at the psychological and social, and probing deeper, because the signal to say, I feel like I'm a burden, can signal a lot of social and spiritual, psychological pain that is might exacerbate the pain. But what has been your interventions or a plan concerning the psychosocial, spiritual aspect of the patient, or maybe even the immediate caregiver, if available?
Thank you so much, Tim. As Tanzile mentioned before, we are trying to conduct a family meeting concerning our patient's health, which is deteriorating. So we have mentioned that the support system is very weak, because the patient was absent for many times. They even mentioned that the patient was a gangster. So everything we get for the family, just take that asset and sell. So in a way, the family is now fed up with him. Everything that needs to be done, including the caregiving support, the patient feels like he is a burden on that regard, because even the mother, who is now a principal caregiver, cannot do the caregiving services to the patient, because now the patient, the mother, is filled with anger. Firstly, secondly, she is fed up, and she don't even want him to just move around in the community, because they feel like ashamed of them having a sick person in that home. So there are a lot of psychosocial issues that we found in that home set. So we were planning to work with the social workers as MDT to see to it, would say the patient is well taken care of, and to find a way, would say, for them to find another caregiver who is a neutral caregiver apart from the family members, so that the quality of life can be improved to the patient.
Thank you, Ncebo. Thank you so much, Mr. Mhlanhla and team. Anyone with a question? Thank you so much, Nompumelelo, to join us today. I just want to ask your status in terms of moving supply at the Manzini government. Mpumelelo. How are you standing? And as far as your supplies, is it something you are having in your stock? And if it's available, which formulas do you have? I'm asking just in case of this patient.
Sanibonani.
Yellow course.
Yebo, Shem. Yathi angisiko sure, but currently we are using tramadol. We have tramadol IV and EPO. Imorphine it has been out of stock, I think, for some time. But what we have been using besebenzisa le tramadol nale nabopetadine currently.
Yeah, we're in a pandemic.
Yeah, but ike yabuya sekuthi nje it's short supply and then ibe nang we had both the IV and the oral ones.
All right. Thank you. Thank you, Nkosi. I was just asking just in terms of this team if they're looking for maybe to take away the weak opioid and use the lower dose of the strong opioids to see if how far they can go. Otherwise, team, anyone who wants to add on this case, this is a real case, something that is on the ground. I like the direction introduced by Mpumi that can we go deeper in terms of counseling? I think from Mr. Mhlanti's comment, we can tell that now, no, indeed there's more. And I'm hoping the social work team will rescue them in as far as troubleshooting the situation and finding out and counseling these family members who are already on anger. And unfortunately, they are retaliating on the last moment of his life. So there's more of some therapy that is needed indeed to help them. And so he cannot feel as a burden to the family. Yeah, I'm hoping they will do more because the grief after this might be hard again, feeling that they have not done anything. And I've heard that there's a child who will be watching and seeing what they're doing. So things done to their parents, children are looking and observing. They might grow up with them and then later they project it on other people. We don't know. So yeah, some in-depth social, psychosocial care may need to be done. And then I'm glad the team also introduced that they are planning also on the issue of end of life care. It will be very nice to empower this client to understand that his wishes, they still matter, even if he feels not accepted, but he still matters because he's him. Regardless of the condition, he is still him. So he can be freely expressing himself and expressive in his wishes, even if he doesn't have he doesn't have any assets, but the fact that there's him and his wishes about life, finding out what it's of value to him at this point in time, so we can direct even our effort towards improving the comfort for him. I don't know if I'm leaving someone behind on this case, but I'm hoping the team will pull through as an IDT when they are roping in the social worker and looking around the pain management, eliminating other psychological issues, impact on the pain, and then see if then need to be transiting to the issue of removing PRN and then giving around the clock dose. Yeah. If then there is none, you are free to write on chat, team. You are free to do so. Let me go straight to the didactic presentation that I have for you today, a very short one, I think 10 or so slides. Actually, it's a summary. I will also use this case as an example to some other aspects of it, just to remind us on how we can deal with pain. But for more details, I will advise that one goes to our YouTube channel and then check previous presentations we have heard there. I also mentioned that you can go there and check Mahlangu MNS. You will access the whole videos there. So let me share my slide. If I'm gone, please buzz me, guys. I might not see. Bam, 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 bam. Let me share the presentation. We have a challenge in uploading it, but we will never give up. We will continue, try, upload it, but we are facing a very, very big challenge. But we will keep on trying. So let me try. Please let me know when you see it. let me do like this. So just to remind you, and then if you wanna dip in, we have one series we had, it was on pain management. We unpacked everything from opioids, prescription, monitoring, we did everything. So it's there in our YouTube, but today I'll just bring a summary. So we're just looking to on pain control for patients facing death and dying. And these are the most neglected patients, sometimes not intentionally, but because they present with many problems. Sometimes one of the problems we find that they cannot swallow, and the available formulas of medication, they are for POs, and then they end up neglected. Sometimes the anxieties and psychological instability that the caregivers go through also make them to ignore these patients. So what we need to understand that one of the principles of palliative care is that it neither hastens or delay death. So it does postpone it, it doesn't hasten it, and we regard dying as a normal process. So with that in mind, we need to understand that we may not change the outcomes of the prognosis, but we can change how the journey to the end of the patient is. And one of the things is to ensure that we maximize comfort and minimize suffering. So I usually say we maximize holistic and we minimize holistic suffering. We maximize holistic comfort and maximize total suffering. So we ensure that the patient is in a pain-free status and he remains there, and the pain-free status is our priority for these patients, and we don't focus on them alone. Like this family we have seen now, they are going through interpersonal pain, and they are going through psychological pain. They are going through, maybe if we sit down with them, you will discover that also they are blaming God himself, or even they have lost what you call a connection with themselves, because spirituality is about the connection between you and your loved ones, the things that you value. So that's our major goal at this point in time, is to maximize comfort and minimize suffering. So whenever we are putting interventions, the first question we're asking ourselves is that, will it maximize the patient's comfort? Will it minimize suffering? So we are not going to shoot all the bullets, but we are going to look for those that will give us maximum comfort and minimize suffering. At this point in time, having the advanced directives in place helps us to be more focused, because we know now what is more of value to the patient at this point in time, and we are able to eliminate most of dilemmas at this point in time. But then once the patient entered to the end of life and dying phase without the advanced directives, it will then be a trial and error interventions, which might not give us or the optimum or desired goals of the patient. So one thing we need to understand is that whenever the patients are approaching the end, we need to understand the types of pain. Physiological types of pain may be somatic, maybe visceral, and then maybe neuropathic. For example, this patient, the lower abdominal might be visceral, but then the other type of pain can then be somatic, which can be localized in the muscle, the bones. And then sometimes then there will be pain in pain, which is neuropathic, which will require us to bring a certain type of drug. And understanding the type of pain helps us then to match the type of pain and the type of drug we are going to use. So we minimize having a lot of drugs until the patient have a polypharmacy. Then we are looking for drugs that will give us the optimum output, but at a lower quantity. Few drugs that will give us a maximum output. So we don't burden the patient with more drugs at this point in time. And another thing is to understand the acuteness and the chronicness of the condition. And most of the time, with this patient, he has a chronic cause, which is cancer, which tells us then that with this cause being chronic, until it is sorted, the pain will always be there. So that's the assumption we have to have, and we need to assess. Whenever we are putting the drugs, then we will need then to choose the type of drug we're going to give. So we have pain drugs that are short-acting, and we have those that are long-acting. So to deal with chronic pain, we know that this is a long-term pain. We need long-term drugs to help us create a good layer to manage this type of. So even at end of life, we are looking for those drugs that will act for a long time, because they may need some time to rest, and the caregivers are tired. So they will need some time away doing their things. So we need to have drugs that will help us deal with the chronic issue. And when we know this is a chronic issue, we don't pray for it to go, because we know now it's not going to go. Only God can do it on his own time. But our duty then is to ensure that, how do we ensure comfort and minimize suffering in this chronic journey? And then another issue as raised by Mpumelelo, it's the issue of understanding the total pain concept. These dimensions of the patient, which is the physical, emotional, interpersonal, and spiritual, or physical, psychological, social, and spiritual dimensions of the patient, they need to be attended comprehensively. The reason is because they act like domino theory. It's like one cause the other. So if you are going to focus on giving the pain medications alone to this patient, you are only tackling 25% of the problem, and you are leaving the 75% of the issues. And then the possibility is it might not achieve anything in the long run. So the best way is to deal with the physical, because that one is the number one thing to deal with. But then once the patient is calm a little bit, deal with the other 75%, which is the psychological part, the emotional state of this patient. Why are you feeling a burden? Dealing with that one, because you will find anxieties there, you will find depression there, and then the more root causes will be surfaced. And then you will find the interpersonal relationship, the family dynamics. This is a person who is a parent and a child or a brother of some sort. This interpersonal relationship within the family, his relationship with the family members matters in terms of pain perception and experience, and it can aggravate the situation. So also addressing that one helps. Then the spiritual area, finding out what gives meaning, what value. One time ago, we met another patient who was a Christian, non-Christian. Surprisingly, when we were approaching the spiritual dimension, and we asked him her source of faith or hope, he said the brother was a source of hope. Why? It was a surprise, because we will assume he will say God, but he said at this point in time, not God met at all, but the brothers met us all. When my brother is available, I feel secured, I feel loved, I feel comfort. So then finding out those things will help us know what to do, which bullets to use at a point in time. So understanding these three concepts helps us when you're approaching these patients at the end of life. And then there are principles that will guide us. Even at end of life, these principles are there. If the patient can still speak, it's a plus. Because on our assessment, we need to know that it is always subjective, and it's what the patient is going to say to us. Another issue that we need to understand is the issue of the use of pain scale. A pain scale helps us to measure how effective are we in achieving the goal that the patient needs. So if then the pain score is moving down, then we educate them that whenever it's around 5, it mean we are achieving the goal, because the goal is not to eliminate pain, but is to alleviate it to a bearable level. So normally, scholars are saying that pain less than 5 and less, it's more bearable than the other side. So we are having to have the pain score. And what is very tricky is that if then there's a new patient at end of life, it's very difficult to educate them to score the pain, because even their concentration level is is limited. So if then it's been some time with you, you educate with them as early as possible the tools you are going to use to measure the pain intensity. And then whenever we're assessing, I will not mention this one, we are going to use the PKRST to get the pain characteristics, but it's better to go further, look at the emotional impact of this pain. And then again, look at the functional impact of this pain. For example, this patient have anal cancer, is a wound, which has an emotional impact. One of it is dignity, and then also functional impact. Maybe I cannot do ADLs as I wished, or I cannot even go out to do my ILDS. So we need to find out the impact, because it will help us to measure if we are approaching the right direction in achieving the patient's goals, and also to eliminate unrealistic goals when the patient is raising them, because the goals must be determined. And then also we learn the verbal cues and non-verbal cues from the patient. Another issue I would like us to remember and continue to remember, we might be in a scenario as a country whereby we are in short of the strong opioids. Actually, science has been proving that stronger opioids, especially morphine, is more effective compared to the weak opioids. Actually, the pharmacokinetics of the weak opioids, it's a long journey for them to be metabolized and then go straight to the opioid receptors to calm down the pain. And it's dependent on a lot of things. And some of these patients at end of life, they are chiastic. So some of them, they are NPO, they cannot drink anything anymore. So yet having the morphine with both formulas, liquid and long-acting formulas like the tablets, it will help at this point in time because of the effectiveness and the side effects and limitations of the weak opioids get us to a level whereby we are ineffective in managing this pain. Even if we are trying, we are not able. So it's very important, but we are hoping, cross fingers, we will pass this valley and our patient shall benefit most. But on standard, we need to understand that the pain ladder will guide us. One thing I would like us to understand from this pain ladder is that we start from the step one in terms of pain management. And then when we are moving to step two for the adult, please don't remove the baseline. Keep the baseline, add the opioids on top of the non-opioids. Like if I'm having my paracetamol, I add my tramadol on top, so that we are having an optimum effect. But then we have a challenge. I don't know other facilities, but I've noticed that in our country, we are having fixed dose combinations when it comes to weak opioids, which is not okay when it comes to pain management, because then the fixed dose combination, one of the drugs will be having a very short ceiling. For example, if it's paracoden is a paracetamol full blast dose, and then it has a codeine of 10 milligram, of 0.8 or 10 milligram. So, and the lower dose of codeine that we can give is 30 milligrams per tablet. So then, to give 30 milligrams of codeine, you will need to give at least 3 tablets of paracetamol, which is up to 1.5 milligrams, which is out of a prescription. Then you can't prescribe 1.5 milligrams, and it has some more limitations because it needs a good liver and all those things, and it limits us to use it. And when you come to tramadol, it has the issues of seizure threshold, and sometimes not good for the elders and frail patient, and then it's limiting you again. So then we are left with nothing to work on than to then prioritize the comfort of the patient and let the other things to say that now we are not intending to do this, but we're focusing on the other issues. But what I can say, don't remove the base. If you have the pure forms, don't remove the base. Keep the non-opioids, go to the strong opioids. But then, let's be careful when we're prescribing weak opioids. Don't combine codeine and tramadol at the same time. Don't. Or hydrocodone if you happen to find a patient having it. Don't combine 2 weak opioids together. Don't. combine two opioids together. If you are giving codeine, teach your patient to take codeine. If you are taking tramadol, teach them to take tramadol, because doing so will eliminate the issue of opioid addiction or dependence. Find out the patient, then now the patient will, the other opioid will not, one opioid will go straight to the opioid receptor, and the other one will go straight to the addiction center. Then the patient will be said to be addicted to that opioid. So the best way is not to combine the two opioids. So whenever you find them with drugs, find out what they're doing, educate them very well to separate the opioids. And with the issues of titration, it's better to use similar drug and titrate it well, other than combining different drugs and titrating. So another issue I've highlighted it is the issue of laxatives, dealing with constipations when we are dealing with opioids. Constipation is a non-relieved, it's an existing side effect of these drugs, and it will never go away. So giving the laxatives, it's mandatory for these patients. And if possible and available, I will suggest we give two types of laxative, stimulant and stool softeners, to avoid patients even also to develop what we call hemorrhoids, because they have to push a hard stool, which is the gastric motility stimulant, but now it's pushing hard stool, and then they end up going to the toilet painfully. So we give them stool softeners. You can have lactulose, or you can give a liquid paraffin, depending on which the patient is accepting. The reason is that we give this because you can't say the patient will drink water, because patients will not drink water and they will end up having fecal infection, which becomes more expensive for the patients. And then also the understanding and the use of adjuvants, also at end of life, they help. Like for this patient, if nothing all is working, we can depend on them on going straight to taking the patient to what we call palliative care sedation, if that's possible. But having those corticosteroids with us, they help a lot. And even some antipsychotics, they help a lot, like having what we call haloperidol. It will help us a lot when they're having some certain end of life symptoms, like when they're having these hallucinations and confusion, and then having the antidepressants, and also having anxiolytics like lorazepam. They help us a lot. I have forgotten the other thing we used to do, which led to fatigue, which we used to give patients to sleep. But then having the lorazepam is better because it refreshes the patient when they are asleep. So understanding these drugs, combining them, can rescue us at this point in time, even when morphine is not here. Okay, and then there are many routes that we have. We know in palliative care we prioritize PO. Until PO is not there, we prioritize PO. Always let's go for PO. And then outside PO, we go for patches, which is transdermal. I've understood that the private facilities, they do have this for those patients who can afford. In government, I've never seen Ventolin. I'm not saying it's not there. I've not seen it. So, but having those patches also can take us somewhere. Injection, yeah, but provided option 1 and 2 are not available, because our goal is to improve comfort and relieve suffering. So injecting now and again and again and again is not going to achieve some goal. It will have some more pain to come. And also intravenously, we also go for that option if need be, and then put our patient and go through an IV. Especially for this patient at life. Sometimes there's what you call patient control analgesia. You teach them how to take morphine pump, and then they go with it home, and then they do that. But I don't think in a public setup we can have that opportunity to take them home, like put the morphine pump. But if it's available in private, they do so. And then sometimes at extremes we go to even to epidural. But the best one that we can go through is oral. The second one is transdermal, and then the worst ones from number 3 going downwards. We can go, the extreme situations will push us to that level, but the best one is always PO, 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 PO. So then I want us to also understand that the breakthrough pain presents in 3 forms. It can be incidental. So when it's incidental, you need to understand and find out the incident that normally predispose the patient to incidental pain so that we can see if there are any alternatives to deal with it, or we pre-medicate before the incident that normally leads to pain. And then also we have end of dose failure pain, whereby then it happens because the effect of the drug is no longer there. And then we also have what you call idiopathic pain, whereby we can do all examination, we rule out psychological, we rule out physical. We can't find what exactly this type of pain is, the cause is. Then you say it's idiopathic, it just comes in and then leads the patient to pain. So recognizing certain pain flares, it's very important when we are giving the medication. And it helps us then when we are prescribing the opioids, especially when the patient is enrolled to long-term effect opioids, then we give the short-acting ones so that they can prevent these flares. So it helps us in that way. Yeah. I want to share. Yeah. So this is one model that shows that breakthrough pain, that whenever we are giving around the clock medication, it creates this shield. And then breakthrough pains, they do like this. So it's very important to assess how many flares are there. 6 times of breakthrough pains in a day, we need to titrate the drug to that level. So it's very important. And when we are doing this, we need to balance the effective pain relief dose with the patient's desire of alertness and consciousness, because as you are increasing the dose, you may find that then in these spaces there's a lot of drug that is waiting to be used, which then may push your patient to what we call unconsciousness or reduce the level of alertness. So whenever we are titrating, but the most titratable drug current is the morphine one, and especially the liquid one, help you as to titrate it a bit and a bit and a bit. But then without that one, we can do the pharmacological conversions, opioid conversions from morphine to tramadol. We then find out that 1 gram of morphine is equal to 10 milligrams of tramadol. Then we can convert and see how far, but the issue will be the limit that tramadol has. It will quickly go to the ceiling and stops you. And then non-pharmacological therapies, they are there. What I can say with the non-pharmacological therapies, it's better to find out when you are doing your aggravating factors in the PQS2 and alleviating factors, to find out those things that the patient can do to alleviate the pain. Even when you are doing adaptive and non-maladaptive coping behaviors assessment, so you can know which are ones are not, to find out what is working for the patient. Because if you give your patient things that are not working for him or her, he might not comply to your prescription of that intervention. And whenever these are the physical therapies, you need to find out the caregiver's capacity to provide some of them. For example, the massage, or when it comes in terms of room for this patient, range of motions, or those minor exercises. And then I've learned that we need to caution them around the issues of cold and heat, especially when they're approaching their end and bedridden. Their skins become very soft and sensitive. So when you say hot water, they will bring in a hot towel or bring ice direct to the patient, and then they would bend the patient and cause more blisters and more pain again. So we need to educate them thoroughly with these ones. And also here with the psychological counseling, psychologists can do, but also the social workers and nurses, they know basic skills in terms of providing counseling. When we talk of this counseling, there's also another type of counseling, we call it motivational counseling. So we help the patient to focus more on the more adaptive behaviors and help them to acknowledge that they can do it, they are the best. So we help them to motivate them forward. So we also can embrace that counseling type of motivational counseling. And also, if possible, you can have the family and have what we call group psychotherapy. Yeah, it can help them to cope with the anxieties. But what we need to understand, like we do with physical pain, until you ask the patient, they will not tell you. So it's very important that you set your tools in a way that when you are doing your assessment, it helps you to ask the patient concerning these areas. For example, the anxieties, the depression issues, so that you can help them to improve their emotional resilience. There are also complementary therapies. One time in our videos, one of our presenters mentioned that in Eswatini, there's a Chinese shop there that offers acupuncture, but for those who can afford. Yeah, so sometimes what I usually say here, the touch therapy, being there to touch the patient, it makes sense and it has a lot of impact on them. And then also environmental adjustment is also can help them to ease and have comfort. But we know these are like complementary therapies without dealing with the physical distressing symptom. You find that the priority thing in the domains of the patient, you need to deal with the physical thing, then immediately deal with these ones. You can't cancel a patient who's anguishing in pain. So you relieve the pain, but then go to the other area so you can cushion and sustain the effects of the medication. But without these three, these therapies will not go anywhere. The pain medications, the physical symptoms will not be relieved enough if these ones are not attended there. And then when we're dealing with the emotional pain, we need to understand that really, as Mpumelo said, that sometimes emotional distress, like this patient, exacerbate the experience of pain. And sometimes acknowledging that the spiritual area also plays a role. So the mind and the body are intractably connected. The connection between here is only known by the God who created us. How are we connected in these 4 dimensions? But then we need to understand that addressing the emotional and spiritual distress can significantly improve pain perception and overall comfort. Evidence is also saying that people who have a strong spirituality, sometimes even when they're in labor, they have lower pain perceptions and improve their own comfort. I usually share that at some point we had a patient from Lubombo who had a problem of cancer, and sometimes drugs will be out of stock, and he will survive only through spiritual connection. So through spirituality, he will survive the pain until he gets his next medication or on refill. So that one encouraged me to say, let's look across those dimensions and assess all the other areas. So it will help us to help the patient. One thing we need to know, I've mentioned that using anxiolytics also helps allay anxiety. And also we need to also deal with the interpersonal support and clear communication. Let the messaging be clear to them and understand the interpersonal issues so we can deal with the problems. So these are the things that are very important to deal with. And then as the team is going up, this is the interdisciplinary team. I may not dwell much on it, but let's look around. In this case scenario, the social workers will rescue us, but also we may need the involvement of the families, or having that family meeting. Indeed, it's key. And for the shared decision, especially in this point in time, and advocating for the patient's needs. So regular reassessment of this patient might be needed at this point in time, maybe that weekly or so. Even if it's telephonically, it will make a difference for this patient, while early referral to palliative care and the team approach are still vital. Maybe to summarize this, I can say that what we need to embrace is that effective pain management for dying patients hinges on multifaceted, compassionate approach and ensuring comfort and dignity. So it's very important to deal with it. And we can go through this through early and thorough pain assessment, as the WHO definition means. Impeccable assessment is very key, and it must be early and must be regularly done. And utilizing the WHO stepwise ladder, it can help us tailor the patient's needs and effectively manage the pain. And choosing the appropriate medication and the administration routes and understanding who will administer the medication can help us for optimum comfort and efficiency. So efficacy, it will help us. And integrating both pharmacological and non-pharmacological methods can also help us at this point in time, especially just being there for the patient. And there's no way, team, we will address pain without understanding total pain, and through an interdisciplinary compassionate care model, we will be able to help our patients. I will say thank you. Even if our patients are dying, we can still help them. Yeah, that's what I can share, team, just to remind you. But for more in details, you can visit my YouTube channel, Maslang MNS, and then go through the other types of pain. We have more details of it. But today I was just highlighting the things we need to understand when we're dealing with this type of patients at this point in time. So at this point in time, we are not going to reverse everything, but the reversible will be reversed. But we are prioritizing comfort and relieving suffering. And if that happens, we need to ensure our patient will die in comfort. So may I open this door for anyone who may want to add? I have 3 minutes on my time. Anyone who may want to add something? Yebo. Okay. In the absence of any question, I would like to appreciate your presence, and I like to appreciate your contribution to the case of today. I hope our students witnessed them. Slanti, thank you so much to mentor them through. I hope they've grabbed something even from the presentation. They will update their notes, and then they will do something maybe before Friday as far as planning for the case, or they will carry this information also to where they are going. What I will say is that dealing with end-of-life patient is not an easy task. There are a lot of things that are surfacing. Like this one patient now is deteriorating, and there are things we will anticipate. I would say go there and prioritize end-of-life and educate them on things they will expect, because just from deteriorating, they are going straight to terminal phase. They are not going to speak anything. Sometimes they will not be able to speak anymore. So educate the families on what to expect and pull them closer to bringing and giving support, giving them the value of why is it important for them to support him at this point in time. We hope through counseling they will heal. Sometimes the patient will die still in the heal process because the damage may be deep and the referral might be late, so the process might take some time. But we are hoping our social workers will do their best. Maybe the patient also may want to apologize also to the families. We don't know. So yeah, maybe the social workers, if they can treat this as a priority, we can have one patient who will die a peaceful death, because we have acknowledged now in palliative care that there's a good and a bad death. So our goal is to give them the best good death that they may experience. So at this point in time, in our next session, we are going to do what you call communication. So we'll be looking at how can we communicate with patients and families faced with death and dying reality. I have a lot of experiences with these people. I hope all of us have. Can we come back on the 3rd of September? Thank God the Mhlanga holiday is on the 8th. So can we come on the 3rd of September? And I wish we could come for discussion at this point in time. Today, how have you managed to communicate with the patient who's faced with the reality of death? How have you managed to communicate with the families faced with the reality of death? We will be looking at that concept. How best can we do it? There's a message from Margaret Gamet that thank you so much, team, for your efforts in making sure the session was a success and it was informative. Thank you so much. Thank you so much, Pumelelo. I hope you are not alone and the Moneni team is here. We need you more, even to advise some of the clients on the clients that are on cancer. sometimes on chemo or related issues. Yeah, I know you now, you're a specialist, madam. So we need you more in our sessions. Your contributions matters most to the team. Thank you so much, Hospice team and everyone who have joined. I can see our lecturer from Babane. Thank you so much for joining too, Mr. Zigalala. We appreciate your presence. I wish one day you can bring some of your students to present a case in this session. That will be very boss and nice, but it's a rather story for another day. Thank you so much, colleagues. Let's meet on the 3rd of September, where we are going to discuss and share on how best we can communicate with patients and families faced with the reality of death. Thank you.